Alright, we're going to be talking about sedatives, antipsychotics, and antidepressants. A lot of stuff to cover this week. So, what is the difference between a sedative and a hypnotic? Just how sleepy it makes you. So, certain drugs can stimulate the central nervous system and increase it, which can make you tense, stressed, anxious, nervous, that kind of stuff. And then you have drugs that tranquilize, which calm you down. And then you have sedatives, which make you drowsy, and hypnotics that put you to sleep. All the sedatives, hypnotics that we're talking about are dose dependent. So it's a sedative at a lower dose and then a hypnotic at a higher dose. Sedatives commonly get prescribed for people who should not be active. So if somebody has recently undergone heart surgery or something, and you need to keep them calm throughout the day and make sure they don't get up and do anything crazy, you might give them a sedative, which keeps them drowsy, fatigued, relaxed kind of feeling. And then hypnotics are normally prescribed for people who have like insomnia. So since we're talking about hypnotics, we should discuss the sleep cycle. So there are going to be 4/5 stages to the sleep cycle. In stage 1 of NREM, or non-random eye movement, you're going to see alpha waves appear. There are 4 major brain waves that we have. You have alphas, betas, thetas, deltas. Alphas are typically the waves you see when somebody's eyes are closed and they're relaxed. Betas are waves you see when people's eyes are open, or if they're consciously trying to do stuff in their head, like think of like math problems or solve stuff. And then you see betas. Thetas and deltas typically aren't seen in adults when they're awake if they don't have like brain damage or seizures. So in stage 1, you see alpha waves. The sleeper is kind of aware of their surroundings, so they might hear some things and startle them and wake them up. And you spend about 5% of your sleep time in stage 1. Stage 2, here those waves are going to be a little bit higher and a little bit lower in frequency. So they're kind of moving out of alpha waves, more towards like delta-ish. And at this point, the sleeper is no longer aware of their surroundings. So you can kind of make noise and they're not going to respond, right? And a lot of your sleep time is spent here in stage 2, about 50% of your sleep time. And then we get into stage 3 and 4 where you see delta waves. These are really tall, really slow waves. And these waves are very important in rest and restoration. So there are studies that are done, and if you wake somebody up in delta, like they are in stage 3, stage 4, this deep sleep, that they don't feel rested and their body doesn't feel restored, right? And you spend about 20% of your time, 25% of your time in stage 3 and 4 into this deep sleep. And then you get into REM sleep. So this is rapid eye movement. We see beta waves in this one. So if you look, they are short amplitude, high frequency waves. It is in REM sleep where you are doing your dreaming. It is very important for mental restoration, and this is when you create memories. So during REM sleep, studies have been done, and it's basically your mind is playing back things that happened that day, and it helps you to form memories. And that happens during REM sleep. Typically, the sleeper is very hard to wake up, and you spend about 20 to 25% of your time in REM sleep. And as you sleep, you start off in stage 1 to stage 2, 3, 4. and then you reverse back through. And so you get to 4, and you go 3, 2, 1 into REM. And then from REM 1, 2, 3, 4 down and up into REM. And you kind of get these cycles. That's why it's called the sleep cycle, right? Okay, so these stages, 3 and 4 and REM, are really important to get a nice, restful, restorative sleep. When we're talking about our sedatives and hypnotics, we're going to be talking about things that bind GABA, or that activate GABA, that activate this chloride channel to depress the central nervous system, to make sure things aren't kicking off, right? So GABA, gamma-aminobutyric acid, binds at a GABA alpha receptor. That's going to open up this chloride channel. That's going to hyperpolarize the cell, which means it's not going to depolarize. This chloride channel also has binding sites for barbiturates. You can see them here. It also has binding sites for benzodiazepines. And then a couple other drugs that act similar to benzodiazepines, so they bind to this receptor BZD1 that we'll talk about in a little bit. So the way that all these drugs work is that GABA binds and this chloride channel opens up. You see this chloride channel has 5 units. It has 2 betas, 2 alphas, and then this gamma. The way that the benzos and the barbiturates and all these work is they help keep that channel open longer, which allows more chloride to pour in. We'll start with the barbiturates. This is your oldest group of hypnotics. Typically not prescribed anymore for the hypnotic effects. More seen in general anesthesia and as anticonvulsants because they are pretty addictive and can be abused. And there's newer drugs that do a better job with less side effects. What we see is your barbiturates increase stage 2 sleep, but decrease 3 and 4. And if you remember, 3 and 4 are 2 of the stages where you really get that restorative sleep, that restful sleep. Types of barbiturates, you've probably heard of these, maybe in passing. Phenobarbital, it's your first one. It's a really long-acting barbiturate. It can last from 6 to 12 hours. Mainly used as an anticonvulsant, so an anti-seizure med. Phenobarbital can give you a hangover, so it acts for a long time, and so if you take it as a hypnotic and you go to sleep in the morning, you might still feel a little drugged, a little dopey, a little hungover. Not to be confused with pentobarbital, so pheno, long-acting. Pentobarbital is kind of an intermediate acting. It takes about 4 to 6 hours. It's a good drug to get you to sleep and to keep you asleep for most of the night, but not give you a nasty hangover like phenobarbital. And then you have secobarbital. This one's really short-acting. Typically, it's indicated as a hypnotic to get people to sleep, but not for people that come out of sleep a lot. And so it'll just help you go to sleep, and then it's out of your system. Sometimes it has a counter effect of having you wake up early. Just one of those weird side effects, right? The side effects of all your barbiturates is drowsiness. I mean, that's kind of what they're there for, right? They're hypnotics. Sedatives are there to make you sleepy. Dry mouth, impaired motor and judgment function. Don't operate heavy machinery or anything like that. They're frequently used to attempt suicide with because they do act really quick, and it's one of those things that you just kind of like drift off. And so it's one that really needs to be controlled so people don't get enough so they can attempt suicide. It is also it is contraindicated for people with acute intermediate porphyria and if they're pregnant. Acute intermediate porphyria. So porphyria is a metabolite that is a precursor to hemoglobin, and so you need it to make hemoglobin. There is a rare genetic disorder that causes a deficiency in the enzyme hydroxymethylbilene synthase. That's a mouthful, right? And without that, this porphyria molecule can build up. It can cause tachycardia, hypertension, and seizures. And so, if you're on barbiturates, it causes this to build up even more. It can cause seizures. You also want to avoid barbiturates if you're on any other central nervous system depressant, and that's going to be a theme throughout this entire lecture. If you are on a CNS depressant, don't take another CNS depressant because it makes it even more depressed, right? Okay, so some of our common hypnotics, benzodiazepines, typically used to treat anxieties, but also work as hypnotics. And so when we get into our anti-anxiety drugs, the benzodiazepines will pick up. We've also covered some when we talked about muscle relaxants. They're also anticonvulsants. Diazepam, lorazepam. These are typically used for sedation and also as anti-anxiety drugs. So some of the ones that we'll talk about: Lunesta, Sonata, Ambien, and then your benzodiazepines like temazepam. So Dalmane, clorazepam. This one's long acting and kind of works like your barbiturates, where the following day you can kind of have that hangover, not feeling so great with it. Temazepam, really immediate, no real after effects on it, works really well for a hypnotic getting you to sleep. Triazolam, this one's short acting and can also work like our short acting barbiturate, where it can cause you to wake up early in the morning. So it's great, gets you to sleep. It's for those people that don't pop out of sleep a lot. So depending on whatever your sleep disorder is, a lot of people have a hard time falling asleep. Some people have a hard time staying asleep. This one is not good for those people that have a hard time staying asleep. It's not going to counteract that problem. And in fact, we'll wake you up early. And so not only are you not staying asleep, you're going to wake up and not be able to go back to sleep. So the way your benzodiazepines work, you saw it right here. Same way your barbiturates work on this chloride channel, enhancing the effects of GABA. They bind the benzodiazepine receptor, BZD, on the chloride channel to increase the opening frequency. They are lipid soluble, so they cross the blood-brain barrier really easily. They're metabolized by the drug microsomal enzymes in the liver, but they don't cause enzyme induction. Your barbiturates will cause an enzyme induction. And what that means is, as you take that drug, your liver will build up more of the enzymes to break down that drug. And so a lot of times with drugs that cause enzyme induction, you either have to scale up or rotate out drugs, and then be careful that they're not taking something else that uses those same enzymes, because that would make that drug also less effective because you've built up more enzymes to counteract it. Your Diazepines work similar to barbiturates, where they increase stage 2 sleep but decrease stage 4 sleep, but they typically don't cause REM rebound. So REM rebound is something that you see in drugs that influence the time in REM. So there are some drugs that decrease the REM cycle or decrease the time you're in REM, and then when you come off of those drugs, you're going to stay in REM longer the next time you go to sleep. So it causes you to have more intense dreams. It causes you to be in REM longer. Sometimes it's just a longer part in the cycle and you cut up pieces of the other side, or you sleep for longer periods of time. Triazolam can also cause rebound insomnia. So a few days after you stop that, you might not be able to sleep. And so it's kind of like a slap in the face, right? So you don't want to do an abrupt stoppage. It's wean yourself off of this so you don't have that rebound insomnia. Contraindicated for pregnancy, do not take it if you're pregnant. Also, do not take it with other central nervous system depressants. Bad idea. And we'll pick up with other hypnotics in the next section.